here. This is a really good book chapter. If you guys haven't seen this, it does have a nice thought here that in order to ensure a child's curriculum is age appropriate and well balanced, it's important to administer assessments that address skills in all areas of human functioning from infancy through the child's chronological age. And so I do caution folks who are using the VB map for a 12-year-old. I understand that some kids coming in into care, there's a huge mismatch between their developmental and chronological age. But I then see folks fall into the trap of teaching a 12-year-old nursery rhymes because they, quote, can't do it on the VB map and they want to fill that in. So I say that with a word of caution. And yes, I went to Western Michigan, which is why she's wearing her Broncos t-shirt for those. Oh, hello, Madison. It's nice to see you guys here on this call. So from this chapter, they do bring in a table of the different kind of assessments that folks may be using. So you can see that the ABLES doesn't have a targeted age range mentioned, but it does, I think, cover quite a bit of the lifespan. Most people are familiar with the VB map, and that's 0 to 4. And then we have the Vineland. That's the acronym of the VABS, and that's 0 to 90 years old. Keeping in mind, too, the Vineland will also give you that really handy-dandy age equivalency score. I think sometimes folks use the Vineland because the insurance companies tell us to. It's a mandate either from TRICARE or it's highly preferred from other providers. And then we use it and then we stick it in the drawer. And then 6 months later, we update it and submit it to insurance and we don't really look at it. And if any of you know me or follow me on LinkedIn, you have heard me say probably half a dozen times that the road to hell is paved with data we never look at. That was something that my mentor used to tell us all the time. I have the water bottle stickers, hit me up during LinkedIn. Happy to send you guys some. But it really is true. Like we shouldn't just be doing it to meet a funder guideline. If we're going to take the time to do the interview with parents, we should take something from it. I highly encourage you to look at those age equivalencies for that particular assessment. So some starting points. As you follow your assessment, as you start goal planning, I'd say these 12 areas are things that we really need to consider. Some barriers to learning, what's their current level of functioning, the acquisition rate. I have 4 blocked out, or 3 of them blocked up here. Number 4, the functionality of the skill, the social validity, the age of the child. So if you think about that introverbal question for a 12-year-old for nursery rhymes, I think we missed the mark for all 3 of those. Thinking about those prerequisite skills, and that goes hand in hand with, child development, the pivotal skills and behavioral cusp we're getting from learning that skills, any complementary skills that we might need to be successful. How many hours of treatment do we have available to us? That treatment provider and what their skill set is, and then finally the available resources to be able to implement it. But we're going to focus a bit more on that 4, 5, and 6. All right, this is another article. If you guys haven't had a chance to read it, I highly suggest that you take a look at it. Don't be dismayed by the age. I still think what they have listed in here is still relevant today, even though it's from 2011. But it says a comprehensive curriculum that targets skill deficits in each of these areas is not enough to ensure quality treatment. The treatment program must be tailored to the individual child's need. Simply having a curriculum available does not ensure that appropriate content will be selected. Again, just because there's a hole in the grid, I see a lot of practitioners just fall into the trap of wanting to color it in. And I get it. I get when you're wanting to report back to a funder, I started with this many points in the VB map, and now I have this many because you were able to shade all that in. I understand the desire to do that, but I'm encouraging you, if you take something away from this, don't be held down and chained to that assessment grid to the point where you're teaching skills that just don't make sense to your learner. It's also impossible to target every skill deficit, so priority should be given to key skills, behavioral cusp, pivotal responses that will remain functional for the child across their settings and over their lifetime. If you look at our BCBA practice of standards or ethics code, it all goes over that too, right? We should be using behavioral cusp. We should be teaching those pivotal responses. So we want to consider what to teach and how to teach it. I'm not sure how familiar everyone is with this resource as well. I did try and make a QR code. I tested it with my phone, so I hope it works for everybody else. But this Captain website, it's free. All the resources here are free. It does go over the 28 evidence-based practices based on 2020. And on the next slide, I'll talk a little bit more about that definition of evidence-based practice. But all the ones that they have listed here, they have free learning modules that go through it as well. You can't get CEUs for, I don't think, but they are free to take. So if you're a little rusty on any of these areas, if you're working with candidates and you want a resource for how to go over some of those topics with them, it's really nice. There's a lot of printable job aids and downloads as well. So I encourage you, if you need more support in any of these areas, to please go check it out. And what do they mean by evidence-based? Evidence-based is not synonymous with there's a published article on it. So if you look on the left, it kind of walks you through that inclusion and exclusion criteria. So it talks about the literature, like where did it come from? So they're including like online peer review journals. They're not including things like dissertations or conference presentations. There's just different levels of scrutiny that those two types of publications go through. They are only picking articles that were published in English, the types of intervention. They're looking at different outcomes, the study design, and then the population and participants. Once they've done that, they do a quality appraisal with a whole bunch of reviewers. And then they have criteria that it has to meet to be considered evidence-based practice, which I have at the bottom there. So again, this is all online. I thought I did another QR. Oh, I thought I made a QR code for that. Oh, I have it on the other page. Yeah, so the QR code will bring you to all of these resources, but it'll also bring you to the downloadable PDF where it kind of goes through this whole evidence-based process if you guys want to read more about it. Okay. All right. Oh, and sorry, my transition came up ahead of time. I do want to talk a little bit about prerequisites again, because again, it ties right back to that, that child development component. So some learning to learn skills. If you have a kid who's first coming into care, so we have some critical prerequisite skills to maximize learning success. So things like attending, being able to relinquish reinforcers, having our hands still and ready. I don't mean like we're trying to completely stop a kiddo from engaging in any self-stimulatory behavior, but like being able to be ready, not manipulating a whole bunch of stuff so we can be paying attention. If it's interfering with learning, that's what I'm referring to. Being able to wait, being able to respond to instructions, and then being able to change our behavior based on feedback. And learning from various prompts in our environment, and remaining calm, which I think is hard for all of us. If you're not sure what to target, I highly recommend you talk to the relevant stakeholders. That includes mom and dad, not just one or the other. If possible, it'd be great to talk to both, whoever's involved with kiddos' care. Maybe that's grandparents if they have custody. Whoever the relevant stakeholders are, I highly encourage you to talk to all of them. If you need help starting that conversation, I am going to do a shameless plug here. I build, in addition to doing consulting and doing CEU events, I build clinical decision support systems. So one of them that is available, there's a QR code for it. You can get a free version, is a family quality of life scale. It's a 25-question Likert scale that gives you some more insights into what's going on with this particular family. Because obviously the client is the nucleus, but there's a whole life system that is happening outside just your client. And if we can't make the needle move for caregivers, if things are great in your clinic and then you go home and it's absolute dumpster fire, I'm saying that you really haven't done a service to that family. So if you need help figuring out what's important to mom and dad, this is a good starting place. It is repeatable every 6 months. So when you're doing your Vineland, when you're doing your VB map or your peak or your evils, it'd be a nice add-on to also include this family quality of life skill too. All right.